Very good. Okay, so as I talked about at the beginning, I had the great pleasure this year of leading MASAM's task force on pain and substance use disorders. And so I am now going to present for you the outcomes of our task force. I have no disclosures. I would love some if you know somebody. And so what was this task force? It was established in fall of 2024 by action of the MASAM Board of Directors and had a couple of goal deliverables, providing a comprehensive literature review of the management of chronic pain in people with use disorders, creation of a policy statement / recommendation on management of chronic pain in these patients, and then meetings with important people to help change the policies and make the world a better place. We had 9 total sessions. Each was an hour. They were time limited. These are the members. If you are on the task force, please stand. You're all out there. These people did so much work. It's unbelievable. And a couple of other folks who are not here today. How did this all sort of work? We started off really with brainstorming, discussion of things that made us nuts. We then spent really 2 sessions doing like a really deep lit dive, one on the primary literature and one on practice guidelines, best practices, that sort of thing. We then spent another session really summarizing and pulling all of that together. Did use some AI, I am sorry. And our hope was to really sort of finalize what questions did we find that we wanted answers to. That sort of ended up being how we solidified what our deliverable would be. And so then we spent a session thinking about what the format of our deliverable would be. We then drafted a set of 10 key clinical questions that we felt needed answers, and then finalized our deliverable. We went through a vetting process where we vetted other folks in the addiction medicine world, folks with lived experience, people at lots of different organizations and institutions, and then finally put it together. And we actually had our very last wrap-up meeting last evening. So what did the recommendations look like? I'm going to talk through some highlights. I'm going to make sure you all have access to the document. The other caveat I will give is that I hate slides with words on them. And I strive very hard to not put lots of words on slides, but when you are presenting the outcomes of a task force set of guidelines, there's literally no way around it. And so I have interspersed the slides of words with pictures of bunnies. This is the link to our guideline. Please snap a shot. It's going to be on the MASAM website. We're also going to develop a couple of things that go along with it, a one-page infographic, an FAQ, etc. But this is sort of where it is now. Everybody got the QR code? Good. So many phones. So great. Did it work? Oh, good. All right. So now bunnies. I really wasn't kidding, y'all. Look at how cute the bunny is. All right, so I'm going to tell you all the TLDR on this. Our first question was for patients with OUD on MOUD who require management of an episode of acute pain. May full agonist opioids be used? And our answer was yes, that in fact they may be used. We felt it really important to state explicitly that a history of OUD, active or in remission, with or without treatment with MOUD, is not a contraindication to treatment with full agonists for acute pain. This includes both planned as well as unplanned pain. And we actually were sort of shocked if everybody says like there's no data. This is actually like grade 1B. So that's actually pretty great. I think we were all a little bit shocked to find that the data that do exist were stronger than we expected them to be. Another bunny. You know, this one's really cute. Yeah. No, I really can't express how much I hate slides with words on them. Our next question for patients with OUD on buprenorphine and moderate to severe chronic pain, refractory to optimize non-opioid treatments, should full agonists be considered? And if so, how should management be approached? We felt that that was a reasonable consideration, and we made it clear that our group has an explicit goal of avoiding causing patients to experience destabilization or further destabilization of their use disorder, as this can lead to a return to unsafe use, overdose, and death. And so we recommend continuing buprenorphine rather than decreasing or discontinuing the dose during the treatment with full agonists for the purposes of decreasing the chances of accidental death. So as you can sort of see, we very much took a harm reductionist approach. We thought that in general, if buprenorphine can be included in a patient's milieu, despite treatment with full agonists, that the data strongly supported those patients were less likely to experience things like accidental overdose. Another bunny. For patients with OUD on methadone and moderate to severe chronic pain, so similar to the last, but in patients on methadone, we felt similarly. We also felt that continuing methadone rather than decreasing or discontinuing was better for patients, that we would generally not want methadone decreased or discontinued. Obviously, conversely to buprenorphine, where there is obviously like safety in the drug itself, we felt that ongoing engagement with the OTP was also an important safety guardrail for these patients in this situation. We did make a comment, everybody's gonna ask, so I may as well say it, about split dosing. Similarly with buprenorphine, the data are really all over the place, and so we felt the need to mention it, but not necessarily make an explicit recommendation. We didn't feel that all patients with chronic pain on methadone must be split dosed, right? But rather that OTPs should consider that split dosing may improve pain for patients in this situation. This one I think is my favorite. And then the question of which meds to use. So in patients for whom full agonists are being considered, who are on MOUD, which meds should we use? We felt that a trial of a potent short-acting full agonist, either oxycodone or hydromorphone, at the lowest effective dose on an as-needed basis was going to be the best initial approach. We did consider other opioids, and there's further language in the document itself that obviously, depending on the specific patient and the circumstances, other opioids might be fine, but in particular with buprenorphine, where it's so potent at the mu receptor, we felt that we wanted to ensure that patients actually would get analgesic benefit from the medicine. And so the best data would support doing that with either oxycodone or hydromorphone. It's a good bun, yeah. It turns out the internet has so many cute bunny pictures. And then the question of follow-up and monitoring, right? I think this sort of goes back to a huge theme of this afternoon and a lot of what Chris Shanahan was talking to us about, right? Like, what do you write in the chart? How often do you see these patients? All that sort of thing. And so we felt really strongly about not making a strong recommendation in any direction, as long as you make a plan of some sort and write it down. We felt that many of these patients likely would want more frequent check-ins. We felt that liberal use of telehealth was probably a great way to do that without dragging people into the visit, but also having multiple touch points with them. We also felt similarly that we should mention the importance of the PDMP and intermittent drug testing, but that mandated drug testing at every single visit has never been associated with improved patient outcomes. And so, like with any situation of a narcotic, we didn't necessarily feel like mandating it at every visit was appropriate. We're nearly to the end. Oh, this one's so good. And then for patients with significant risk of ongoing illicit use or those with risk factors for accidental overdose, right? So people who are also prescribed benzos, people with underlying pulmonary disease, we felt that considering prescribing very short courses with very frequent follow-up was potentially a way to avoid harm. This obviously has to be balanced over the clinician's ability to do that, right? But that in general, for some of these patients who are at highest risk of accidental overdose or bad outcomes, finding a way to see them as often as is needed for them to be safe, especially initially, was an important thing. We also wanted to make it extremely clear that documentation was of the utmost importance, and sort of specifically wanted to say sort of the benefits to other providers, like the other people who care for these patients, who see them in urgent care, the pharmacists were expecting to fill these prescriptions, right? That we really need to be diligent about exceptional documentation, our reasoning, our plan, so that all the other members of the care team can also be in agreement with the plan. And discussion. That was very abbreviated. There's more in the document. I urge everyone to go ahead and read it. But yeah, questions.
Ruth Poe, TBHN. Okay, so what's the plan to get Mass Health Pharmacy to see this and to really influence the change that we need to have happen in our good state? And are you presenting this at ASAM, because the deadline's October 1st, to make that submission? Because I believe we're the only state that has come up with these guidelines, and it would be great to roll it out nationwide.
Yeah, actually, yes, agreed. 1000% agreed, Ruth. So our task force's last meeting last evening was really spent sort of discussing exactly that. So ASAM submission is planned, and then how to roll it out to orgs like Mass Health, like the private insurers, Board of Registration in Medicine, Board of Pharmacy, those sorts of things, potentially looking to publish it in some place sort of formally. But if folks have specific ideas of where they want these recommendations to be, who they want to see them, or have direct connections, please, please, please let us know. Like, we're very much in the, like, we're now planning what to do with this phase. And so we want all your ideas.
Heidi Ginter. Thank you, Josh. This is amazing. And I think that we're probably at a stage where we really should have a consortium of community hospitals that are sharing best practices and really pushing the envelope forward. I know that we have that meeting once a month that's led by BMC around that piece, but I feel like this needs to be part of that, because that's the leaders who are in the community hospitals and beyond. But I really feel like we have so much power in our community hospitals that if we can start doing this really well there, it's an easier lift to go to the tertiary care. But I feel like the community hospitals are where our patients need this. Does anyone have any thoughts about how to make like a consortium of our community hospitals so that we can all start doing the same thing and sort of rise all the boats?
Continue thinking on it. Any final questions? Are we actually going to finish 5 minutes early? Ooh, here's a question coming.
Comment to make. First of all, this came out of last year's meeting. Do you guys remember we were here and then we had this hour-long talk on pain and OUD, and we were all like, what just happened? That didn't cover enough. And we were left with more confusion and questions than anything. And so this thing, led by the great Josh St. Louis, happened. And this group that worked on it really did an amazing job. And it's the first time I can remember that it sort of like organically grew. And that was awesome. And we definitely want it to be spread. I was going to say one other thing, but I'm taking a lot of time at the mic. I can't remember what it was. I'm going to step back and have you go on that.
Hi, Connie Flynn. I'm a nurse practitioner. I run a substance team at Berkshire Medical Center in the Berkshires. But on that note, we actually, our healthcare system, we have now 2 smaller community hospitals. I'm in Pittsfield. It's still a community hospital, but it's a big community hospital. But there's a smaller one in hospital in Great Barrington, and there's one in North Adams, satellite facilities. And what I do now is they actually can consult me. They started consulting me, but I didn't have any way to do it. So I actually either FaceTime, I work with the patients and stuff. I mean, I don't get a lot of consults, but now they know, like we have Tiger Connect, they know to call me and stuff. So I'm actually in one hospital working with 3 hospitals. So there's ways you can do it, telehealth ways. And then the providers up there are kind of learning some of the ideas and stuff that I have. So it works anyway.
And I think that was, that was something that our group discussed, was like, do we recommend consultation of some sort? And in the end, we sort of discussed that there are many options for said consultation. We talked about mixed up specifically and others, but also recognizing that depending on your context and where you work, that may not be realistic or reasonable. And that, you know, talking to your colleague who sits at the desk next to you may be like as useful as something like that. So, but the question of consultation very much did come up. And I think, you know, for many of us is a hugely important part of how we can do this work. Yeah.
Okay, this is my final thought. There are people in this room who are nurse practitioners, PAs, internal medicine, family medicine. This, plus a case on pain and OUD, should be presented at a conference by any one of you the next year. Like, we all have those conferences upcoming, the local ones, the AFP conference. We've got to spread the word on this. And you think somebody in North Dakota or California is going to do it? No, it's going to be us. So I want you to pause and ask yourself, when is your PA conference? When's your NP New England conference? When's the deadline? Look it up. And any one of you can take this, put together a panel and run the show and educate more people. So that's sort of the charge we're giving you.
Audra.
Hey, Audra Williams. I'm out in Lowell, and we have a consult service. One thing sort of related to this, like how do we spread the word and what is our comfort level? We have a couple psych NPs on our service that have not had a lot of experience with pain management and have just like less comfort with this in general. So our team has multidisciplinary MDs, NPs, psych, medicine to sort of support that. We're affiliated with Tufts Medicine. Right now, they don't have any addiction medicine providers. They only have a psych team and their addiction psych provider left. So there's truly just like a general psych CL pool. And they've expressed discomfort with managing pain. The addiction psych doctor, or addiction psych doctor before was even managing some PCAs and sort of had stretched her scope that way. But just maybe words of advice on how much psychiatry can tackle this, and if there's any limitations on their scope to be, you know, close partners or managing these patients without medicine support.
Yeah, it's such a good question and very much was something we discussed, right? And so in the end, our task force did not make an explicit recommendation regarding whose role is it, but rather that it just has to be somebody's role. And that, you know, we sort of specifically said, right, like addiction medicine folks with, you know, either like an IM or FM background are likely most comfortable with managing these medicines, but that the reality is that this will likely be non-addiction medicine PCPs sort of like first line. Yeah, Olga, you had a...
Can I just answer here? So I'm a psychiatrist. I don't have any formal addiction of psychiatry training, and I've been doing addiction work for the past 3 years. So I was able to get out of the Berkshire Medical Center residency with enough comfort as a general psychiatrist to do that. I'm board eligible now. I'll take the board. So I'll be saying I'm an addiction psychiatrist next year. But I think as a psychiatrist, we should be able to contribute at least and be comfortable with that.
Yeah, and I think that was the other piece of it too, was the like, anybody could be. And it's, I think it's just a question of willingness, right? And I think it goes back to, you know, the like, don't tell me that you can't prescribe opioids kind of thing, right? Like, because you can just like say it. Yeah. Phoebe.
I just want to make a little bit of a delineation that I think some of the things in this talk are really like, or that you are recommending were really standard of care like 20 years ago. And the problem, and some of them are really more cutting edge and possibly controversial. But the big problem, one of the big problems is that the standard of care of somebody who has a broken femur leaving the hospital on Tylenol. I was just saying I had a patient who got a kidney transplant, a patient on methadone, he was on like 90 of methadone. He got a kidney transplant like over a weekend that of course he'd been waiting for years. And then he came out of the hospital and he said his transplant surgeon at Tufts gave him 10 tabs of Oxy number 5. And he was in such severe pain. And he told me that the transplant surgeon told him, well, I can't really treat any pain on top of it. You're on enough methadone to kill a horse. This is a transplant surgeon in 2025 who probably has 30 years of training. So what I would say is that one of the things that everybody in this room needs to do is give some really basic talks, especially to the surgeons and the anesthesiologists, and really make like, because let's fix the really basic stuff that is still happening and is still like really just not evidence-based and based in stigma.
All right, this will be our very last one.
It's a lot of pressure.
Better be a good question.
Oh, yeah, I guess. Matt Rogalski from Acadia, a couple places. So I just wanted to get out the thoughts in my brain when you started to talk about how do we roll this out and get it out there. I think for the community hospitals that are lucky enough to have addiction consult services, that's an easy on-ramp to go to the CMOs and the rest of administration and say, let's get going with this. For the others, if there are partners in the community, either for buprenorphine providers or OTPs that are doing a lot of collaboration together, or you maybe have somebody's ear at the hospital administration to maybe yank on that ear and see about getting that going. But I would agree with Phoebe that one of the big things will be probably that we get out there, we get in there, we do grand rounds at the hospitals, because they're all going to be desperately salivating for guidance of any kind on this to make their lives easier. So I think it's just going to be about starting the process, and then I think it will organically roll.
Thank you, everybody.